And we will continue with Dr. Sorin Ghia, imaging the musculoskeletal tumors, what the orthopedist should realistically ask from the radiologist. Întotdeauna o provocare, întotdeauna o mare provocare în momentul în care, bună ziua, domnul doctor, vă mulțumesc foarte mult pentru prezență și pentru participare. Într-adevăr, e o mare provocare. Ce să întrebăm și cum să interpretăm imagistica atunci când avem astfel de cazuri? Vă ascultăm cu mare drag.
Hello everybody. Thank you so much for inviting me here. I suppose I'm one of the few radiologists in this session. And I am proud of it because musculoskeletal image is something that I really love. So we will discuss today in this presentation about musculoskeletal imaging. This is my radiologist point of view. And I don't find the button. Where is the button? I'm sorry. Okay. So we already know that primary bone tumors are relatively uncommon, but they carry a great burden, especially on young people. The discovery of X-rays and the invention of radiographs changed the face of medicine forever. And today we have a plethora of imaging modality derived or not from X-ray. So we still heavily rely on radiographs, which is the backbone of modern radiology. So why is the radiograph so important that we still use it today? These images are from an article from Times Magazine, and you see evolution of X-ray machine and radio protection from 1910. Since 1935, you notice the heavily protected radiologist trying to do an X-ray. And nowadays things are very much evolved. We use 1,500 times lesser radiation for one radiograph, and also the exposure time is now 21 milliseconds compared with 90 minutes at the beginning of the 20th century. So after 125 years after the first radiographic image, medicine immensely evolved, and the experience acquired in this century of radiological knowledge is still useful. My previous colleagues already discussed the important aspect of radiological aspect of tumors. I will like to emphasize some elements from my point of view as radiologist. First of all, radiograph is important because you can see the pattern of bone destruction and you can see the lesion margins. Because when a bone lesion, a tumor destroys and replaces normal bone structures, we see a radiolucency which is equal with an osteolytic lesion. So we as a radiologist we report it as osteolytic lesions, not as a cyst or a solid lesion, because we cannot differentiate that on X-ray. Bone destruction is easy to be seen in cortical bone rather than in medulla, because medulla has less trabeculae. You are of course familiar with patterns of bone destruction, geographic patterns, which is characteristic for benign bone lesion or slow growing malignant tumors, and sometimes infectious processes like Brody's abscess. And the other two types of bone destruction are mouse eaten pattern and permeating pattern, which sometimes cannot be differentiated one of other, but it is not that important. Important is that they usually represents a very aggressive type of lesion, probably malignant. Another reason why radiograph is important is because you can see reactive changes in the host bone. So the bone is trying to limit the growth of the tumor, and if it is a tumor that grows slowly, like in a benign tumor, you have a sclerotic rim. If the tumor grows faster, and the faster the tumor grows, the less organized is the sclerosis around the lesion, with some exception, myeloma being one of them. We can very well see periosteal reaction on radiographs, and I know that you as orthopedists are looking very carefully for this periosteal reaction, because you can appreciate if the periosteum is intact, as in benign lesion, or if the periosteum is damaged, interrupted, like in this malignant tumor. It forms a Codman triangle, or you can have a spicular pattern which is highly suggestive of malignancy. Also, on a radiograph, we can appreciate the tumor matrix. A matrix is an indicator of a structure, the tumor structure, or it is an indirect indicator of biologic activity, especially when this kind of matrix changes over time. We now know that if it changes over time, it seems that something has changed in the tumor. Maybe a benign tumor started to become malignant. So we have osteoid matrix, chondroid matrix, fibrous matrix, and sometimes no matrix, like in a simple bone cyst or giant cell tumor. And the radiograph also gives us information regarding location of the tumors, because some tumors we know now that they have a predilection for specific bones, like chordoma in sacrum or spheno-occipital region, or all these others. And could be a predilection for the site within the bone. Some tumors prefer metaphysis, diaphysis, epiphysis. And another thing very important is multifocality. When you have multifocal lesion in children is one kind of a story. When you have a multifocal disease in adult, it's a different story, because in adult it nearly always indicates metastatic disease or multiple myeloma. So what should we do with all this the information that we get from CT and MRI nowadays? We have learned that from classic radiology about malignancy on radiographs, and that might not be true on MRI. It might, but it's not always the same. So we need new classification and grading systems that incorporate MRI and CT imaging. And this is a tool. This is a tool that the American College of Radiology, ACR, provides for us, the radiologist, and this is in a form of a guide, an evidence-based guidelines for appropriateness criteria, which is extensively analyzed for current medical literature, and it is reviewed annually by a multidisciplinary expert panel, and it's freely available on the internet. So we can consult this tool at every tumor that we encounter. I will briefly present this guide, because I think it's important to understand how radiologists are thinking and how they are judging the presence of a tumor inside a bone. So we have 6 variants. The first one is when we suspect a primary bone tumor, and what is the initial imaging. And the initial imaging is always radiographs. It is the most appropriate imaging for all the reasons that I already discussed previously, and CT and MRI are not routinely used. Variant number 2, when we suspect a primary bone tumor, radiographs are negative or do not explain symptoms. What is the next imaging study? The guideline says that the next logical step, usually appropriate, you see it is in green here, It is MRI. So MRI detects radiographically occult pathology like in bone or in surrounding tissue. You can see other pathology not related with tumors, but which can cause symptoms like bone contusion. You see on this knee here, bone contusion. You can see occult stress fracture, which is not visible on X-ray, and it is useful to biopsy planning, and sometimes you give contrast, IV contrast during an MRI examination, but it is not mandatory. And because MRI is so good in contrast tissue, in differentiating tissues amongst themselves, so you don't really need contrast to delineate or to characterize a bone tumor. CT would be the third step in this case. You can see some non-displaced fracture, subtle periosteal reaction, or some occult bone tumors, and it's useful in regions complex and where anatomy overlaps, but it's usually useful when the patient cannot have an MRI. So keep in mind that MRI would be the first next step. And also we do not give contrast with CT usually. In variant number 3, we suspect a primary bone tumor. There is benign radiographic features of this tumor, and it is not osteoidosteoma. What would be the next imaging study? Usually an asymptomatic like this non-ossifying fibroma, asymptomatic benign appearing lesion on a radiograph is usually incidental, and it typically requires no further imaging evaluation. So there is no recommendation to follow up. But if you really want to follow up this lesion, CT and MRI might be equally useful. Of course, MRI will not give any X-ray to the patient, so I would prefer MRI. In variant number 4, we suspect a primary bone tumor. The radiograph and the clinical presentation suggest osteoidosteoma. So what would be the next imaging study which can confirm or not the suspicion of osteoidosteoma? Well, CT is considered the optimal imaging modality because it is extremely sensitive for detection and precise delineation of the nidus. MRI is generally considered inferior to CT in evaluation of suspected osteoidosteoma. You have an example here. So a radiograph shows nothing, but the patient had symptoms like pain during night, relieved by aspirin, and long-standing pain. We did an MRI because we didn't want to irradiate the patient. It was a child of, 15 years old. And we see this bone marrow edema on this right image on MRI with a small shadow inside, but we cannot delineate clearly a nidus. But when we perform the CT, you see very clearly the nidus, you see sclerotic margin of the lesion, and also some small calcification in the center, which is quite pathognomonic for an osteoidosteoma. So CT is better than MRI in this case. Variant number 5, when there is a primary bone tumor on radiograph, it is indeterminate or aggressive and suggests malignancy. What would be the next imaging study? So lesions that are not definitely benign on radiograph usually require additional characterization with advanced imaging modalities. So MRI is considered the preferred imaging modality for staging of bone tumors, Sometimes we can do MRI and CT because they offer complementary information regarding soft tissue, which can be better seen with MRI, and regarding matrix mineralization, which is better evaluated with CT. But if both modalities are available, the authors of the guidelines suggest that MRI is always preferable to CT. With MRI, we can also give contrast in enhancement, so we can see dynamic enhancement. We can calculate some enhancement curves of the tumoral tissue, and this gives us more information on the malignity or benignity of the tumor. But the studies have mixed results, so there is no real consensus on this. And there are other techniques with MRI which are quite useful, like diffusion weighted imaging, in which I probably explain this a bit. Diffusion weighted images, it's a technique in imaging that provides information about circulating water in compartments of the body. So water is free to move usually in body, but when you have a tumor which have highly number of closely packed cellularity and a lot of cellular membrane, the water cannot circulate freely, and this is something that this sequence shows us. So if we have restricted diffusion, as we say in our language as radiologists, this usually means that there is a suspicion for malignity. There is other cases when the water is restricted, but it is out of the scope of this work. But keep in mind that diffusion weighted imaging is a special sequence that I prefer to use at every patient that has a tumor, and if it is positive, well, it gives very good information, and it increases the confidence level when you judge the malignity of the tumor. CT, the same aspect here. With or without contrast, there is no consensus, but if you do an MRI with contrast, there is no use for CT with contrast. You have here images of this malignant tumor with a FDG PET CT done after CT and MRI and after chemotherapy, which shows remnant of tissues and some synchronous tumor on the femoral neck. The last variant of this guide is when we find incidental lesion on an MRI or CT done for a different pathology, and it's quite often that the patient comes with a, ACL rupture, and we see an enchondroma at the high level of the distal end of the femur, which sometimes is not completely in the field of view because the technician wasn't paying attention, or because the enchondroma or the tumor was too large. So the guidelines try to answer the question what to do next. So consensus is that we should do a radiography. You see here that we have some diffuse modification of bone structures and periosteal reaction of the tibia, which is very difficult to characterize with MRI, but it easily characterized when you see the radiograph, and of course it was confirmed as a Paget disease. So radiograph would be the first step, and we can also perform another MRI if the first one was not dedicated to musculoskeletal, or it was not enough good quality. So we can repeat the MRI, and we can also give contrast IV in order to better characterize it. And CT could be useful, could be appropriate, but MRI is clearly better. And MRI with X-ray is indeed the winning combination. So this ends my first part of my presentation, and this is my favorite citation from this 1998 article. So the radiologist should never ever, not even once, render an interpretation of a CT or MRI scan of a suspected bone tumor without first reviewing the plain radiograph. So that concludes everything. Never interpret or judge a tumor, bone tumor, without X-ray. This is very important for radiologists to know, because nowadays we are all very, very keen on reading MRI and CT, and I admit you forget sometimes that radiograph is so important. So now that we know the order and what to order in terms of imaging, what is the next step? It has been already discussed on previous lectures that there are classification, important and popular classification of tumors, and most of them are surgical or oncological classification, like this King or the American Joint Committee on Cancer, which predicts the outcome of the tumor based on different factors. But do we have a radiological classification? So the answer is none. We do not have a clear and recent classification. Until this month, in this year, in July, when Professor Avnish Chabra from University of Southwestern Dallas published this article with a proposition of very nice guideline or how can I say it, an osseous tumor reporting and data system, an OT-RADS classification it is called, and it is a system scoring similar with BRADS. Some of you might be familiar with BRADS because it's a scoring system for breast tumors, which is very popular and very useful, and it tries to standardize all the discussion between radiologist and the clinical team. So OT-RADS can help radiologists identify malignant from benign osseous tumor, and if very important, will help radiologists to apply a consistent terminology and reduce imaging interpretation variability, and also improves interdisciplinary communication and patient management. So OT-RADS is a dynamic document. It's a work in progress, which can and should be further refined and updated, and I would like to briefly present this. This is 6 classes from 0 to 6. OT-RADS 0 means incomplete imaging. You do not have enough information to judge something. OT-RADS 1, it's negative, you don't see anything. I will develop in the next slides, but I would like to explain you the table behind the table, why this classification or scoring system is so important. In my opinion, is because it takes into consideration not only the radiographic findings, which are here in this column. They keep in mind also demographic and location, the MRI characteristics like T1 weighting images, T2 weighting images, marrow edema that you can only see with MRI, other MRI imaging features, and post-contrast characteristics of a tumor, and margins, periosteal reaction, and soft tissue, which are judged globally, not only with X-ray. So this is only the first table, first page of 3 or 4 pages of table, I think, with a lot of information, and all the tumors are classified like this. So OT-RADS 2 is when the lesion is definitely benign. Like in this image, you see a lipoma, you see a non-ossifying fibroma, a cyst. Usually these lesions have no enhancement, or if there is enhancement, there is quite thin, less than 2 millimeters of periphery of septal or septal enhancement. I will not discuss diffusion because not every center uses diffusion, but it is written here in case somebody wants to for the future to understand and judge diffusion. And recommendation would be to leave it alone, but the clinical team can follow up as they like, and of course we are happy to follow up this lesion, but it's not usually necessary. OT-RADS 3, these lesions are probably benign, and the probability of malignancy is less or equal to 2%. This is a group of tumor like this one, including Paget disease, giant cell tumor, and chondroma, in which enhancement is variable, and the follow-up recommendation is from 3, 6, 12, and then 24 months, or until the lesion spontaneously resolves or regress. And of course, the surgeon could decide intervention if there is any suspicion of malignancy. OT-RADS 4 is when the lesion is potentially malignant but still indeterminate, and the suspicion malignancy would be around 2% to 50%. In this class, the authors of this article include enchondroma with deep endosteal scalloping, more than 50% of endosteal cortex, osteoblastoma, and grade 1 osteosarcoma. You have some example here. You see in the row, on the bottom row, you see an enchondroma which broken the cortex and it's outside the bone. It has the similar characteristics, even the diffusion of a benign tumor of enchondroma, but biopsy proved that it was a low-grade chondrosarcoma, and the same with this osteochondroma, which has a huge cartilage cap, and after resection, it proved to be a low-grade chondrosarcoma. So it is recommended to have tissue biopsies, and if it's not possible, at least a short-term follow-up for 4 to 6 weeks, and then decide again and eventually rethink this stage. OT-RADS 5. This is where the lesions are highly suggestive of malignancy. The malignancy it's equal or higher to 50% likelihood of malignancy. We include here osteosarcoma, Ewing, pleomorphic sarcoma, lymphoma, multiple myeloma metastasis. On MRI, this tumor have mixed intensity with solid and fluid areas. So you see different kind of metrics. This is a huge chondrosarcoma. You see here all the characteristics of a malignant tumor of the femur, and the recommendation is of course tissue diagnosis, biopsy or resection. And OT-RADS 6 is when we have a known biopsy proven malignancy or a recurrent malignancy, when there is a solid nodule or a residual growing mass with the surgical bed, and it has the imaging feature like the pre-intervention lesion, then you suspect recurrence. And this is the in the upper row you see the original tumor, a synovial sarcoma, and you see in the lower row that appeared a nodule after 4 months after the surgery on the biopsy tract, and this lesion proved to be a recurrence of a synovial sarcoma, and since then the patient had 18 surgery intervention for 18 recurrences. She did also radiotherapy and chemotherapy, and this tumor keeps on coming. So it's very important to detect this recurrence early and to treat them clinically appropriate. Is something more regarding advanced imaging technique? Yes, there are a lot of stuff going on in nowadays, because we live in a very interesting times. Artificial intelligence is amongst us, and of course medicine benefits a lot from artificial intelligence. This is a very fresh article from the Nature magazine, which offer a perspective on, I don't know, 8 pages I think, about the present and future of radiology related with deep learning, machine and neural networks, and what can artificial intelligence can do. And it is quite amazing that in the near future we will be able to link some characteristics of radiological characteristics of some tumors with genetic features, with prognosis. We will be able to predict from some biomarkers. These biomarkers in radiology are these radiomics. With this radiomics, we will be able to predict the future response to treatment, the future characteristics after biopsy, just from images. But of course we cannot do that without the help of artificial intelligence. You need to understand that for artificial intelligence to work and the deep learning machine to actually learn, they need hundreds of thousands and maybe millions of images to be fed. They need to be fed with this kind of images. This is something that in a lifetime of a radiologist we cannot see, that kind of enormous numbers of imaging, but artificial intelligence could do that. So interesting times are coming. In the end, I would like to conclude what can you actually or reasonably ask from a radiologist. So first of all, you should ask the radiologist to guide you through imaging technique in order to choose the best one for the patient, and to provide information regarding aggressiveness and non-aggressiveness of the tumor. You see now that we have some tools. We have ACR appropriateness criteria, we have this OT-RADS scoring system, and of course we have older classification system which stood the they are still popular and very well known. So basically we need to provide you enough information to help you decide what to do next. We can guide you to do a biopsy or a surgery, and we also need to identify eventual recurrence after tumor resection. And as I always said, radiologists should always be available to discuss cases with orthopedists, and they should raise red flags whenever it is necessary, because communication is very important for the good of the patient. Thank you everybody for listening to me.
Thank you very much. I asked Professor Sandroy. He has some questions regarding that excellent presentation. And now I know what we should do with a radiologist. Okay, thank you very much. It was very good.
Thank you.
Thank you. Professor Sandroy?
Okay, I also congratulate to this really excellent lecture. And I have only one question, not very scientific. In Hungary, the PET-CT, the use of PET-CT is not supported by our national assurance. How is it in Romania? Because there are evidence that PET-CT is very useful for some aspect of primary bone sarcomas and also for soft tissue sarcomas. And we are always fighting with our national assurance that they should support this, and it is not the case. Still today, it's very difficult to get a PET CT, for example, for assessing the Ewing sarcoma, if it is a disseminated part or it is a localized Ewing sarcoma. How is the situation in Romania?
Well, in Romania, situation is, I think, better than what you explained us. It is possible to obtain a PET CT after you do a file from the National Insurance Agency, and sometimes it takes a while, but in the end, the patient can get for free a PET CT. So from this point of view, we are fine. The problem is that, as you know, PET CT is very irradiating techniques, but of course, when you put in the balance the information that you obtain versus non-obtaining this information or the irradiation, of course, it's in favor of doing PET CT in high-grade malignancies.
Thank you.
Okay. Thank you again, Dr. Ghine. And